Welcome back to Our Invite Podcast. My name is Nima.
I'm Aaron.
And this is episode 3, and we're here joined by the Memorial Health System team. We weren't planning on having everyone here, but hey.
It's a team effort.
It's a team effort.
We got a whole starting 5.
Teamwork has been a constant topic on the show, so we're glad to have you guys out here.
Thanks for having us.
Thank you.
Good morning.
Thank you for inviting.
Everybody doing well today? Had a Cuban coffee? Everything good?
No, still working on it.
Where's my cafecito? All the coffee. I skipped the coffee because I was counting on napping all day.
Sorry about that.
Is that what you guys do in the ER? That's
no,
what happens in
only,
the ER.
only on the days off. Only on the days off.
All right, so since we have a lot of people here, I'm just going to go down the line, let you introduce yourselves and your role here at Memorial.
All right. Well, my name is Brad Rogers. I'm a clinical pharmacist specialist in the emergency department at Memorial Regional. So I work hand in hand with the trauma doctors, the ER physicians, the nurses, and the PAs in the ER to get the medications quickly to patients and help them with any kind of emergencies that arise.
Awesome.
My name is Amanda Brahim. I am the clinical manager for the oncology and hematology division for the Memorial Healthcare System. I think that's just a fancy way of saying I help all of our pharmacists to be part of a multidisciplinary team to provide care for oncology patients.
Good morning. My name is Natalie Zilban. Officially, my title is Medication Safety Officer, but my role really has expanded more into a system pharmacy role. So I get to work with these great folks, with our physicians, our nurses, and really with our executives. So it's great to be here. Thank you.
Hi, I'm Sara Eltaki. I'm the clinical coordinator for pharmacy services and transitions of care at Memorial Regional. With transitions of care, what I do is I try to transition patients in and out of the hospital back into the community setting. So whether that be home, back into their physician's offices, communicate with the outpatient pharmacies. So it's a lot of those types of movements. And then, I help with the system kind of develop their transitions of care programs as well.
Last but not least.
My name is Dr. Dorinda Segovia. I'm the Vice President of Pharmacy Services for Memorial Healthcare System. And my role in the healthcare system is basically do whatever these people ask me to do.
That sounds good.
And in addition to that, strategically plan for the profession of pharmacy within the healthcare system and beyond. I directly oversee 3 very distinctive pharmacy lines within the healthcare system: the retail pharmacies, the specialty pharmacy, and the home infusion pharmacy. I also work directly with the pharmacy directors in the hospital, and I work with the team at MCI, as well as Natalie with medication safety. We all have very ties together. And Sara with transitions of care into the ambulatory setting in and out of our healthcare system.
Okay. Thank you guys for all joining us.
And the only thing I would change on that is I would have loved for you guys to say doctor. So I don't know if we can.
I don't get hung up on that. I don't
You
like
don't,
that.
but it is branding our profession, and for these guys is something extremely important as they move towards the future.
I guess because
I'm
at least
like you.
in our division, like between the pharmacists and the physicians, we're all on a first name basis, so it feels strange. Like we'll introduce each other as Dr. Whoever.
So I guess I screwed it
but
up.
then
for them.
we-
Introduce myself.
I just said introduce yourself. So
I mean, I feel like that's just.
It's funny because everyone in the profession refers to themselves as first name basis,
And, it's
and we don't know the first
we're
names,
like
we know the
awkward,
last
because
name.
we're like, we're not on your
Who's
level, so we
Amanda?
always say doctor, out of respect.
You just call me Zilban, so it doesn't even matter. No doctor, just Zilban. It's all good.
It's a big movement actually within the profession to make sure
It's
that we
been a
use
long
our
time.
professional
Yes,
degrees.
it has been.
Even when I was in school.
And we even have new grads that are saying, this is known out there that we have this degree and we are very shy of using it. And I think what's important is not to use just the degree of doctor, but to say, I am a pharmacist. And so tie the ties. We're not misleading people thinking that we're physicians. It's just making sure that they know that we are doctor level professionals.
Yeah,
understand.
I've had some people in the profession, like pharmacists, say, "Oh, we don't like using the word the doctor in our face because we don't want to
I'm
act
one of
like
those.
everyone's more better than anyone else." How do you feel about that?
I think sometimes you have that because what you're trying to do, I feel like a pharmacist is a more accessible healthcare professional
Right. Yeah.
sometimes, and
Exactly.
patients will open up to you more. So me using my first name when I introduce myself to a patient, it actually breaks down some barriers. So
Yeah,
I feel
that's
like
true.
if I have a little bit more of a familiarity and that helps me get more easily to the core of an issue, it's totally worth it, and I'll drop the doctor in a second.
But I think amongst other healthcare professionals, I remember being in school and my teachers and my professors would say, elevate yourself
of course.
in front of, whether it's the nurses and the doctors. But I do agree with you, Amanda. As, having gone to patients' homes, had I introduced myself as, hi, my name is Dr. Natalie, the white coat syndrome would have immediately set in,
Yeah, sure.
and they would have really shied away from answering.
Exactly.
So I do think there's a fine line. I do think for students, though, and especially in academia, I think referring to oneself as doctor is important. But I think with like our colleagues, like if I were to walk into my boss's office who happens to be a physician, and I was now demanding like, hey, call me doctor, he'd laugh in my face.
Because you don't call him, you
No,
both are on
I
a
call him
first
doctor.
Oh, you do?
So I actually call all
Okay, so
physicians
we're all on a
doctor, so
first
it's
name
different.
basis. So.
Okay.
So I think it's very different.
It's to fill out, your relationship. Every
I think
relationship's different.
it's the relationship that you
Exactly.
have,
Yes.
what you're trying to accomplish, and who your audience is, and that's why I got a little bit confused. I don't want to interrupt anybody, but I wanted to settle that in your eyes, what you're trying to accomplish.
Yeah, we always refer to everybody as doctor.
Yeah.
Yeah,
Out of
there's
respect.
some people
Out of
that
respect.
come up to us
Yeah.
and like referring to my first name basis.
And
I'm
like, no,
nah.
I don't feel comfortable calling you first name.
Yeah, and then I also add, because more recently, giving more talks that are more multidisciplinary in nature, doing cardiac conference, multidisciplinary trauma conference, it is important to say doctor.
Of course.
Yeah,
Because
of
it
course.
changes the way that they're going
They
to receive the
perceive
information.
So your
Perception.
audience
Yeah.
for this for
Absolutely.
this podcast, the purpose of the podcast and the purpose of the audience, what is your opinion?
So our audience is healthcare professionals, just in general, and
It's
as well
literally
as-
split down the middle with students and healthcare
because
professionals.
we get it. The reviews we've gotten, it's been
I don't mind introducing myself again and leaving the doctor out.
So, when you guys, what do you wish you would have known when you started out in your careers?
I wish that I knew how many different types of certifications you could get that were also multidisciplinary. Okay. For example, we have a pharmacist, Alberto Ogston, who is a diplomat of the Applied Board of Toxicology. And that certification, there's less than 80 like in the world. There's very, very, very limited, but there are certain rights that also grants pharmacists.
Yeah.
So when you're researching for, let's say, ACCP or those things, you're thinking about getting BCCCP, also ask, is this a certification that also can grant me more rights in the future? There are states that actually have laws set up where pharmacists are able to do more when you have BCPS. As far as changing medications, as long as the pharmacy is, or the doctor's physician's office is actually notified.
Oh, okay.
So really researching about the certifications and what else that comes with it. If you're a requirement for a particular type of program because you have that certification, then that ups your value tremendously.
I think for me, so I actually went to school in New Jersey, which is like the industry capital of the world,
Yes.
right? So I literally Rutgers.
Hey, New York.
Well, Rutgers is the industry capital. Literally, all the pharmacy industries are right there, right? So, so I, when I was going through school, there were really three paths, or at least three very clear paths. There was the industry path, the community path, and the clinical hospital path. But what you really don't realize, and I feel like my career kind of is a staple of this, is that there's so many opportunities outside of what is within those three paths, but still a lot of opportunities. Transitions of care was not even a thing.
Yeah.
It wasn't a concept at that time.
So is that weird to think that P1U wouldn't even have known that you're doing something that P1U didn't even know
P1
existed?
was like, I'm not doing a residency. Why would I add another year? But I ended up adding 2 more years to my, so I was like, oh, this is not. And even into my P4 year, I was like, I'm still not going to do a residency until I actually started my APPEs.
Okay.
And then when I saw things I thought I wanted to do, and I was like, oh, I actually don't really like it. And then when I went into another area, and I was like, oh, I didn't even know pharmacy could do this.
True.
It was really cool. And then when I started kind of seeing, the one thing I would always say is like, there's always need for pharmacy, and it's just a matter of creating that path for yourself. You know, like again, one kind of quick story with this is I remember in my PGY 1 year, I really wanted to do pain management. And I remember my residency director telling me, there's no role for pharmacy in pain management. And I was like, what? Mind you, this was 11 years ago. So I was like, well, and then of course me being stubborn, I was like, well, I'm going to find a way to do this, you know? And then so I found a way, and then I ended up in the transitions of care realm, which again didn't exist. So that's one of the things I kind of wish I knew, is that be open to anything outside of like what those 3 clear paths or even more than that are. So
I would probably say that nobody sitting at this table ended up where they thought that they were going to be in their first or second year.
No.
I hated oncology in school.
I wanted ambulatory.
Oh, wow.
I wanted to be a diabetes like expert and like
Wow.
adjust.
you couldn't pay me enough money to be in ambulatory care. Literally, ambulatory care. I was like, why would anybody want to do that? And now that's what I'm doing. It's
And
so
I think
funny.
that speaks to the role that we have as preceptors to make sure that we are able to instill those other opportunities and bring them up to students that may not know what they could do.
Exactly.
Yeah, we feel like there's a big gap in, you know, our education, because we don't, all the positions you have, we honestly don't learn about, to be totally honest.
Yeah.
Of course, we're out there in the community, and we
We didn't
understand
learn about
that.
it
But
Same way that you didn't learn about
None of us knew, and
transition
so
care.
10 or
Yeah.
15 years later, nothing has changed. That's
Correct.
Yeah.
It hasn't changed.
What do you think? Like you say you don't want to. You thought you would never do residency. You say you would never oncology. You
No.
hated it. What triggered that? Like, what do you think?
an
triggered that
actual experience.
Yes.
Okay.
An actual experience. And I remember being in oncology and thinking, this is probably the most autonomy, the most symbiotic, multidisciplinary relationship. And I just looked at this and I was like, wow, there's so much that you can do here. There's so much of an impact that a pharmacist can make. This is exactly what I went to school for. And that was something that while I was in school, it just didn't translate for me. It was just, you know, you learn regimens, you have to memorize, like
Exactly.
anthracyclines do this, chop, mop, whatever. And it just didn't make a lot of sense and it didn't click for me.
That's so funny.
And whether it's with patients or being on the inpatient side, figuring out how much a pharmacist has an impact on an actual patient outcome, I was like, I can't get this anywhere else.
True.
Yeah.
And for me, actually, the really funny thing was I almost had the similar path. So for PGY2, I actually ended up in drug information, which again, you're like, what? Where did like you've been everywhere, right? So I did a PGY2 in drug info, and actually the reason why, and I didn't understand it at the time, is I really liked the investigational part of finding things out. So I liked someone asking me a off the wall question and being like, huh? And trying to look and dig for the information. And then that actually translated into my current career. So with transitions of care, a lot of the times there's this like little missing link to understanding what's going on with the patient. So that still intrigues me of that searching and like trying to figure out like, why is this patient keep coming back, and trying to find that little piece of information. So I use the skill from drug information, which sounds kind of like, and I know it's everyone's favorite class and subject, because stats is the best.
Said no, whatever.
What is the power?
But taking that and like translating it into a career, so I used that skill set going forward, and I made a connection. Like it wasn't really about, oh, diabetes is okay, it's this and this. It's really kind of, it's like a puzzle, and I really like that concept of trying to put the patient together in whole as they're separate in pieces, if that makes any sense.
Yeah, so I think there's in each of our jobs, there's certain aspects that are universal that attract us. So would it mean that maybe I could be happy in an ER ICU setting? Maybe, because there's enough of that same team collaboration, same reliance on your pharmacist. You're an integral part of the team down there. They'll probably don't want to start anything without their pharmacist, and it's the same feeling in oncology. So I think you're right. You can get little skills that you pick up along the way and you apply them to your current job, and that's really what makes you happy and what gives you that professional fulfillment.
Yeah. And for me, it was just somebody tapping me in the shoulder and saying, "We think you could do this." And I'm like, no. Administration was the rotation I liked the least when I was a pharmacy resident. And I hope that person's not watching, but it was just, I couldn't connect, right? Administration, I could not connect the dots between my administration rotation, both as a student and as a resident, with the practice of pharmacy. I had a real hard time connecting that. And I stepped out of my rotation, my residency training, and I was ready to be a clinical coordinator for life, right? That was my path, and that was my winning aspiration. And I didn't see beyond that because I went to pharmacy school to be a clinician. So connecting the dots, and then when you get tapped on the shoulder, closing the door to an opportunity that comes to you, it's not the right thing to do. If you think you could do it, if somebody thinks you could do it, try it. You never know where you find the hidden gem. This is what you ought to do. And I am now, fast forward X amount of years later, I refuse to disclose.
10 years, right?
2 years.
10 years. No, 30 years after graduating from pharmacy school. You find yourself saying, wow, I had no idea as a PGY, as a P1 or as a P2 that I would end up doing, pharmacy administration and pharmacy leadership. But now I can connect the dots. I can see the impact that has on pharmacy practice, and I am totally vested to do that, and I really enjoy it. But if it would have not been that somebody said, you ought to consider doing something like this, I would have not seen it.
And I think it also speaks to pharmacy education, because I know that when I went to school, it was very didactic. I went to school in New York, and I was that year where the PharmD was no longer optional. So I went from the RPH, and my year was the one that everybody had a PharmD. And so there was only two paths, unlike you. So we had two paths. You either were really smart and you did the hospital path, or you were great and good, but you ended up doing retail. But pharmacy school, and I think all professional schools are very didactic. They do not give you exposure into what really happens in the real world. I think your first exposure is when you start doing your rotation. And even then, I still think you're so young in who you are, both as a professional and as a person. You don't know yourself well enough to really know what it is that you want to do. I can tell you that I always knew I wanted to do something in psychiatry. So that for me, I grew up with a mother who worked with mentally ill people since I was a very young girl. So for me, it was a no-brainer. I was going to end up in that. I actually went to ASHP looking at residency programs, ended up interviewing with McKesson at the time at PPS, and they said, we have a great gig for you. You can work as a psychiatric pharmacist, no residency.
Oh, wow.
So,
Have time shift change.
right? Which is why I know I'm kind of dating myself, but it tells you where the profession was, where I literally hadn't walked yet for graduation, and I was already working and licensed as a psychiatric pharmacist.
That's awesome.
But I knew that inside my heart, that's what I wanted to do. So I felt lucky that I knew what I wanted to do. I don't think and we've heard it around the table here, I don't think you know what you want to do. You want to be a pharmacist, but what does that mean? And I can tell you, just in my career, my role has changed. And if you were to tell me I would end up where I am today doing med safety, I would tell you I don't even know how that path would connect. But that's, I think, one of the exciting things about our profession. Is that our profession is not just, you don't just have to do retail or just hospital. Your profession, our profession, you can do everything and anything. And, and I will tell you, I've now sort of worked my way into population health. And I work very closely with Sara, and there is a need for pharmacy and our footprint is tiny.
Okay.
And if we need to expand what we do, because it's really it's the physician, it's nursing, but pharmacy has a role in value-based medicine and what we do. So it's exciting to see our profession evolve. And stuff like this is exciting because how many students even know about this? So,
True.
so I think this is great.
So when you speak about expanding our roles, how do you think is the best way to go about that? This is for everyone. What do you think is the best way? I'm sure we can speak for like an hour on this, but
Oh yeah.
Yeah.
Oh goodness.
So, I mean, I think that there's various, and you have various different professions and paths in this room, like we mentioned, but I think looking for that opportunity, like looking to see where's the opportunity. So I can talk about the population health transitions of care area. At the system level, they were starting this population health, and I don't know if you guys know what population health really is, but it's really, instead of looking at the patients within the hospital or the four walls, you're really looking at your community as a whole. They started to build out this program with nurses and social workers. But at the same time, we knew that medications was probably the number one reason patients were coming back and falling out of care. So for me, this is what I did. Hey, we're here. I'm not even joking. That is not even a sarcastic thing. I actually went up to the VP of Pop Health and I said, do you realize what pharmacy can do for you? And initially she's like, oh yeah, MedRec. And I'm like, it's much, much more than MedRec. I mean, MedRec is a very vital role and a vital process, but I was like, it's beyond that. And so she was like, she kind of didn't understand it at first, and she's like, let me see. And then we started working together, and she even tells me, she's like, you kind of blew my mind with the amount of things that pharmacy catches and sees. And I always say that, I know it's kind of an addition to what the question was asked, but she was like, my nurses ask the same questions you do, but you hear something totally, and the patient can answer it the same exact way. You hear something totally different than what my nurses heard. And I said, yes, and that's the benefit. And so that was the way that we sold pharmacy practice in that area, and we were able to expand out.
I think what you did really well there is that you educated and you redefined the scope.
Correct.
And so nurses have a great scope of practice where there's things that nurses do and that nurses catch that no other person can. There can be a nurse and they say, listen, I have a bad feeling about this patient, something's off. Nurses have amazing assessment skills and amazing patient care skills. We are the medication experts, and we should continue to brand ourselves like that to both the public and our colleagues in the healthcare profession. I think you did that wonderfully.
Yeah, and I can also speak my position. Like I said, I was hired as med safety, but my role and scope has evolved because I have placed myself. So I not only do med safety, I do diabetes, I do
It's
pain.
redefining your scope.
And expanding what pharmacy does, because I think for the most part, people don't know what pharmacy does.
Yeah.
They think all we do is dispense.
Exactly.
Maybe they'll call us once in a while, but they don't know what pharmacy can do and the amount of knowledge that we truly have. So I think, what Sara did was, hi, I'm here, but I nudge my way into meetings. I nudge my way, and that's not a nice word, but
until they get to a point where they say, we cannot have this conversation without
so-and-so at the table. And I think that is so important. But I think that also comes with us as pharmacists being comfortable doing that.
Yes.
And I think, if you were to ask pharmacists 20 years ago, where they saw themselves, it would be very different.
Correct.
So I
We've
think
traditionally been a very introverted, behind the scenes.
We talk about that all the time.
And I was like, and you have
Kind
a
of
group of
way.
very extroverted, and
Right, and we were in the minority
Yes.
for a long time.
Yeah.
The chatty ones were not the
I
the
remember sitting
majority.
in class and my teacher looking at me and she's like, "You're gonna be trouble," and I'm like, "Look,"
Well, that's what you
but
described.
that's kind of
Yeah, what you described is the transformation of like our ER pharmacy.
Correct.
Because when I started, the way you found out something serious was happening was you were walking around to go see another patient and you saw a crash cart and a bunch of people in a room. So it went from that to paging it overhead internally to the ED to I'm walking to lunch. I'm not even working on the floor. I'm going to see a friend and they go, Brad from pharmacy, come to Trauma Bay. So
That's
you
how
have
you know
this
that
clear
you've
transformation.
not that you've made it, but that's how you know. Like
you're an integral part of the team, and they don't know how to function without you, and it's great, and that's how you grow.
Now, something, and I will say, especially with the code responses, everybody has something that they're strongest at. And the nurses, they're trained all day in patient assessment, hands-on. If you're there, you understand the medications, how they're dosed, you can prepare those things ahead of time. That means that the nurse and the physician who is trained to do very specific things, you do your specific thing, they have more time and the outcomes get better.
And there's nothing better than seeing a code that's run smoothly, where everybody knows what they're doing, there's calm. I mean, it's hectic, it looks hectic at some degree, but everybody has their role, everybody knows what the other person is doing, and it's a beautiful thing to see. A bad code, on the other hand, oof.
Yeah.
A lot of you guys say that, like, once again, you guys never knew what it was. And I feel like nowadays there's a lot of new jobs just being made, like new position titles that never existed or just popping up just because someone has the credentials to be able to do the job. What roles are you curious about nowadays? Are there any curious roles that you guys are looking into? And
so there's one that that Dorinda's helping me pitch into for our next fiscal year budget, and that is an oncology informatics pharmacist. To help with treatment plan development, treatment plan upkeep. If you think about oncology, there's no other branch of the medical field where as many new protocols and new drugs are getting approved at just lightning speed. The FDA, which traditionally has, the process of drug approval has been rather slow. Now with breakthrough designations, drugs are coming out of the pipeline quicker than ever. This means that we work with an electronic medical record, so new treatment plans have to be built and applied to patients. I mean, we're talking about the moment a drug gets approved, the moment the FDA bulletin comes in, I get text messages from the physicians that I work with. Hey, Amanda, hey, when can I start prescribing this? How quickly can we get this? Do you have the protocols in place? And there really is a need for someone who's a medication expert, who has clinical experience and who also can speak IT, which I'm not fluent in. So we're creating that position. It's not a brand new position. Some of the larger academic institutions have had these types of positions for a while, but we felt a need, and so that's one of the roles that I'm excited about developing, and I don't know exactly who we're gonna fit in there. Hopefully a clinician who speaks IT.
Do you think there's an extra certificate or something that someone could get to be more qualified for that position?
So for our specific electronic health record, there are additional trainings that you can go to up in their headquarters. So we use Epic and Beacon, and so you can go there and get trained. It's different courses for drug record building, treatment plan building for the different parts. So yes, those are available.
And another role that I can think of also in the oncology area, as well as cardiovascular and psych, is targeted therapies. We've already started engaging our pharmacists in getting certifications for pharmacogenomics. We actually have one of our pharmacists, and we have two other pharmacists certifying the system, but we have a pharmacist who actually pursued the master's at University of Florida to do that program. And so those are innovative. They're being done already. We're not new to it, but growing that service line within Memorial, within the practice of pharmacy, it's another new role that's emerging.
Yeah, UF has both the master's program, and then they have a shortened precision medicine course where you actually get to analyze your own genome, which is pretty cool. I thought that was
really interesting.
So you do coursework ahead of time, then then you go up there for a few days, you do more didactics, and then you do a project at the end. And part of it is analyzing your own genome and seeing what that means. So precision medicine, I think, is really going to come more and more to the forefront. I think oncology is one of the first branches to really use it for virtually every patient, but it's going to come along to be the mainstream rather than the exception.
And we at Memorial are already capitalizing on such technology. We've had our own lab that helps us with targeting therapies for patients who have malignant diseases.
Nice.
So, Dr. Rogers, I actually want to direct this question to you. So, we talked about how we have to show our value. So, in the emergency department, how are you viewed, and how do you work with the physicians? Like, are you, Because back in the day, pharmacists may not have gotten much respect as they do now. So how's that relationship with physicians as well as other people of the healthcare team?
Yeah, every day it's growing stronger and stronger. And some of the biggest things is, one, taking care of the medication reconciliations with the patients was huge.
Okay.
If you picture, if you say you have like 20 technicians, everyone does one med rec, or say 3, so you have 60 patients. Because 60 patients get touched, imagine how many medication errors you avert.
True.
So then your ER docs love you, and then because they know that if the admitting doc changes the medication, they're actually changing it, or if they're adding something, they're actually adding something, or you've figured those things out.
Okay.
So then there's that. The second thing is in talking with them, as we identify grander issues, like let's say you have to call poison control on a patient.
Okay.
Let's say it's a beta blocker overdose. One of the treatments with that comes high dose insulin, where you have your regular patient who would be getting 10 units. They're going to say 1 milligram per kilogram, and they run 1 milligram per kilogram per hour.
Okay.
And then you have to figure out how to do that safely. So you have a patient getting 100, 200, 300 units of insulin infused. And if you're an ER doc that has 8 other patients, then you say, hey, I can take care of this. I'll show you what I have when I'm done.
Okay.
Then they will love you forever.
I think what you're getting at is it's just innately in you to show your value by being helpful.
Right.
And by
Exactly.
trying to do what's best for patients,
Exactly.
you're helping your colleagues, and it just kind of flows from there.
Yeah.
I think the moment you shy away and you say, well, I don't know,
Yeah.
I can, if you have that personality and you say, let me take this over for you, I can help with this and take that load off of you so you can do what you're best at.
Yeah.
I think that's how you move the profession forward, one case at a time.
Exactly.
And I think you also need to ingratiate yourself with whether it's nursing. How can I help you? And I think no matter whether it's in the ED, oncology, transitions of care, it's showing how you can help them. Because everybody's busy. At the end of the day, I mean, whether you're a nurse, you're a doctor, you're a pharmacist, we're all busy. We all have so many tasks. And how can we take the load off of, you, and how do I take the load off of you, but at the same time showcasing what we do?
Yeah.
And how can I, assist you with my expertise? I think that is tremendous. And that's how pharmacy continues to grow, and not just lick, stick, and what was the last thing we used to do? Pour. We can do so much more than that.
Yeah, and
but you
really-
have to show them that value.
Yeah, and also really keep creating, I guess, new service lines, or just creating new protocols and procedures that they're not going to understand. So you may not understand everything about Digibind, but if you put it in a protocol where the doctor can click it and order it, and then they understand why they're giving it, and then it's just easy to go through to comprehend. Like, pharmacist education changes everything.
Yes.
Between myself and Norman, we probably do at least 2 to 3 nursing educations every other week. Bare minimum, nursing and physician things. Norman has stroke education for the entire department, and it's actually a requirement.
And
to
add to that, the offering is not only the clinical advancements. The offering is things that are not tangible, right? Like the education.
Yes.
You can't touch it. You can't feel it. You cannot pass it on. You offer it, and you offer it better than anybody else, because, like Amanda said, we are the drug experts. So to me, the offering, looking at the offering as, it's not only the cognitive clinical service to the patient, it's also the offering to the nurse. Being able, and for the young students like you guys, it doesn't always have to be, that clinical path. Delivering the right medicine to the right patient at the right time with the correct dose. Distribution is an incredible offering. If you do it right, if you master it, you are being a conduit to that patient care that would never happen on time without you doing
And
proper
I would argue that you
distribution.
really cannot build anything else until your distributive services are on point.
Exactly.
Yes.
Yes.
Because nobody wants to hear what expert advice you have
If you
about
can't
what this
get
needs
it
to
in
happen
time.
to the
Yeah.
patient, and they're like, well, thanks, but I can't get my meds.
You know,
It's great if you can do the
Exactly.
Vanco level, the kinetics, and follow up and make a recommendation, but if you cannot get that Vanco
Nobody's
dose
gonna listen.
right after they
Right.
took out the trough, we're not gonna deliver.
You know, I
So it's
think-
looking at pharmacy as a whole.
Absolutely. As a whole, yeah. And I was going to
And
say
you want to have
something.
it hand in hand.
Right, and I was going to say something kind of in tangent to the question that you initially asked, Dr. Rogers over here. Sorry, I was going to say Brad, but, we're trying to be more formal now. So, the other thing that I do want to say is I know when you talked about relationships with physicians, that doesn't necessarily need to be in the clinical setting either, right? I think that in general, historically, pharmacists have taken a very passive role
Yes.
in how they deal with their prescribers. So, did you really mean to prescribe this, or
I'm just
I'm
double
just
checking
double-
because maybe you might
I'm
kill
not
this
sure.
person.
Yeah.
But that gets back to Dorinda's point with the doctor, because you're
mean Dr.
right.
Segovia?
Yes, Dr. Yeah, because traditionally, you're right. We have very much sort of taken the back
Yeah.
seat.
And I also,
Yeah.
but that also lends hand in hand to actually the retail setting, and that's kind of or the community setting. I want to make sure because we need strong pharmacists in that community setting
Yes.
who build relationships with their prescribers in their community.
I would argue that it's so much tougher for
Of
them
course.
though than it
Yeah.
is for us.
Of course.
I-
There's
They don't
no
have the
face
direct
to
There's
exactly.
zero
And
face
100%,
time.
but that I think you can build that relationship over
and that
time.
right there, their role in the community setting, their challenges in the community setting is what gives the segue to our integration of pharmaceutical
Yes.
services within the healthcare system.
Oh,
So
one
out of
the-
every chaos, you create an opportunity to elevate the practice. And I think one of the things that we have very unique in Memorial is our integration of pharmacy services. From the time that patient comes in, you get, like Dr. Bradley in the ER, passing on to Sara, to the inpatient pharmacist.
Dr. Sarah.
Dr.
Dr. Eltaki. Let's do that again, passing it on to Dr. Eltaki. And then to the pharmacist in the community. And we now have retail pharmacists embedded in our hospitals to be able to provide that service. And when they leave, we also have a transitions of care team willing to make that phone call, check on them, check on their compliance. And we have a team that is also integrated, looking at their compliance packaging. Do they have the right tools to do their weights when they have CHF, to ask them how often do they have any compliance challenges, any issues getting to the physician to follow up their appointment, because our goal is to service them, but we don't want them back in our institutions. And so that integration and the challenges that it presents to our partners in the community pharmacy setting is what we then capitalize on to advance the practice within the healthcare system.
Oh, one other thing to add, sorry. One other thing to add on when Sarah was talking about communication. This is another reason why it's very important to pursue residencies and pursue some of these certifications. I was in a unique position where when I graduated, I tried to get a residency that didn't match, worked for 2 years in the hospital setting, then did residency for 2 years as a non-traditional resident, and then started working. And the difference between my communication with other providers was, I would say, the biggest change. Because I was already working in the emergency department, on and off. I was already lead pharmacist, so I was familiar with all the medications, where they go on those things. Yeah. But what I did not have was those consistent interactions with the physicians and the nurses. I mean, for a month straight, I was with a nurse in the room for a whole month with ECMO patients. For those who don't know, ECMO is when you put the patient on bypass, cardiopulmonary bypass for a month. So you're learning directly what the nurse has to deal with, what the physician deals with, all the recommendations that go in and of you, and then you have to develop those communication skills. So
I
for
think
me,
it puts
it's
you
into
in
that.
touch with that patient that's at the end of the line.
Yeah.
I think sometimes that disconnect that happens also in the community setting is there's zero FaceTime with the professional colleagues, with the physicians, APPs. And then the FaceTime with the patients is rather limited as well. And so I think residency puts you in contact just with everyone who matters, which is your patients and your colleagues on the medical team.
And that's also the best part about emergency medicine, because that connection with the patient is right there. So unlike when you're on the floor, you have to round with 16 patients. So you have to look at your paper and up until you have time to round with them. So you see them for maybe 10 minutes and then you're out. For in the ED, I might be with the patient for 30 or 45 minutes if there's something dangerous going on, or you're just like popping in and out, or you do their med rec and those things. So the patient interaction is always there. If I say, hey, we need to give this med, I see the effect almost immediately.
Don't you miss it though? That's the one thing that with ER, I've always felt like you never know what happens with these people afterwards. Isn't that like... So you're so intimate with them for a short period of time, and then it's like, okay, bye, I'm never going to see you again.
Okay, so funny story about that. So years ago, we started the medication-assisted treatment program, right? And after I finished residency, I think the program was going for a while. There was a patient that basically remembered me from the trauma bay.
Oh, wow.
And I ran into him and gave him our Narcan kit, one of the first Narcan kits when we started the program. And he remembered me from the trauma bay.
Wow.
So that was
but the thing is that you're going to have frequent flyers. So there are patients where they see me like every month or every 2 weeks.
That's what I love about oncology is that I get to have those relationships for years and years.
Yeah, true. Yeah, so you will see them, and and sometimes they'll remember. They may ask for you. It's like, hey, I survived thanks to you. Thank you. You will get that from time to time. It's not every day, but you will get that from time to time.
Right.
Like we said, pharmacists are introverts. Where do you think that
No.
we can
Please.
change?
Nobody in this room.
Nobody in this room. But I feel like majority of them, or a lot of them, are just like
I think traditionally, yes.
Go to work, get the paycheck, go home, not go above and beyond, go out of your way. Why do you think that is, and how can we change it? Does the school start at school?
I think it goes back to the profession as a stereotype.
And how it marketed itself. I think historically, pharmacists were almost marketed as you get to have a professional degree, but you get to have banker's hours.
Yes.
We talk
And
about
so,
that.
and there were people who specifically enrolled in pharmacy school for that reason. They didn't want to take 72-hour call. And that's still a reality for many of our physician colleagues, that they have to now advocate in their profession. So this is something that has historically been working against us.
So how do we change it?
So I
By
think
having people like us move it forward, like
things
grassroots.
and these programs right here show, what are the pharmacists able to do? One of the biggest things for me, having been faculty and having obviously been a pharmacy student, is I remember being a student, and I remember being like, grades are everything, right? Because they make you think grades are everything. Yeah. And then when I finally
what's going to be asked on the test? How is this going to be on the test?
So then, So then I remember I used to have a classmate who was like C equals Pharm D, and I was like, I can't believe he thinks like that. But hey, he's a pharmacist. Yeah, he's not wrong. So one of the things that I noticed is actually being on the faculty side was, and I found this really interesting, is the people who kind of shove their heads in the books were the people who really actually had the hardest time advancing in their career.
Yeah, we always speak about that.
It really is. It's because they don't know how to expand outside of the academic setting, and they don't really know how to be involved in the professional setting. And so I think that, like I said, pharmacy
but we're also not asking them to do that.
We're not. No, I mean, actually, NSU does I will say, having gone to another school, having taught at another school, having taught at NSU, NSU does a really good job of getting you guys to be more global in the way you think, and saying not only are you supposed to do academics, but be involved. They actually force you your peer 1 year to be involved. And so I think that's one of the things, and I think programs like this saying, hey, in order for you to be effective with communicating with your providers, you need to be able to speak to them effectively. You can't just be, hey, again, excuse me.
I got to answer test. That's not going to help you when you're speaking with a physician.
That's wonderful.
And I think to your point, what can we do about that? I think the schools from the time that they entertain candidates, they're doing a very good job at looking for that extroverted pharmacy technician, pharmacy student coming into the colleges. And they've been doing this for quite a while. That's why the colleges of pharmacies have implemented interviews, because in paper, you really cannot get that extroverted personality.
And it doesn't mean that everyone has to be an extrovert. I mean, it's not a one-size-fits-all. It has to be a nice blend, because there is room for everyone.
But at the end of the day, you have to be a strong communicator, regardless of your personality.
And it
type.
doesn't, you can be an introvert,
Yeah.
right? So
Yeah.
this is the biggest misconception. Everyone's like, oh, an introvert. You can be an introvert, but when it comes to your professional career, you just need to be able to communicate. Go home and shut off.
Don't talk to me.
Don't talk to me for the next 8 hours. That's
so have
fine.
you guys heard of the new term? It's called ambivert.
Ambivert.
So an ambivert is somebody who is both.
Okay.
Where you can be both an extrovert, but when you need to detach, you become an introvert. And so you can be both of them safely without having to compromise. So I know initially you said, oh, Natalie's being very, very shy and very timid. But the truth is, for those who really know me, is that I can be both.
Yeah, you got to pick your spots.
I can be, yes, I can do this, not comfortably. But at the same time, I do like quiet time. And I think it's okay.
Yes.
And I think that, I think one thing that I have always thought is, you can't be cookie cutter.
No.
I think, to say that every pharmacist has to be an extrovert, I think we're doing a disservice to the profession and to us as people.
You have to be a
I think there is no
communicator.
such thing as a cookie cutter approach, because you can be very introverted. I have seen some very introverted pharmacists who, when they talk about what they do, they glow. And you're like, oh my God, where did that come from? So you cannot be cookie cutter. We cannot say it's a one size fits all. If you find what lights you up inside, that will show.
Yes.
So there is no one, there's no one size, there's no one person. You have to feel it in here. And you got to feel that fire in the belly, kind of getting to the interview. You can tell when someone has a fire in the belly. And it's fun to watch it. I've seen some of the quietest people with fire. And you're like, oh my goodness, this is what the world's about.
And then you also see the people who come into the interview. Why do you want to be a pharmacist? Oh, because I know I can get a paycheck. I'm like,
People will say that during interviews.
And guys, and that's okay too. You know what I mean? So I don't know about
I'm going to zoom in on your face when you say that.
Guys, different things motivate different people. And and there are some great people who come in and they do the 9 to 5. Maybe they
But
won't.
they have to care about patients. You have to care
I mean,
about
listen, but at the end of the day, but we have plenty of pharmacists who, they don't want to talk to anybody, and they're great pharmacists, and they manage that verification queue. There has to be somebody who does that too.
But I would still want that person to be passionate about what they do. If they don't want to talk, that's fine. And like you said, not everybody has to be an extrovert, has to be super bubbly, has to be super chatty. But I would want to have a profession where I would be able to say that every person is passionate about what they do.
Exactly.
Yes. And
Agreed.
And not just
I think
nice to have.
justice to your question. There's different steps. So they are skills, right? You can get an introverted person who has passion, right? And the communication skill, how to deliver the message, can be a taught skill if you have the right mentorship. And again, I'm gonna go back to all of us who are preceptors. All of us who have a responsibility to developing pharmacy students. I was just mentoring a pharmacy student last week over the phone, and she said, but English is my second language, and I have all these barriers. And I said, today is the last time that I hear that from you. I arrived to the United States in 11th grade, and I did not speak English. You are only gonna be good as what you want to be, right? Again, define your winning aspiration, and everything else that is in between, tackle it. Learn it. There are skills that can be learned. Talking to the physician, talking to the nurse, talking to your technician. People feel sometimes what does it take to be a pharmacy leader? And they're looking at a position. No, pharmacy leaders are behind every counter. Just by statute, right? Yeah. Florida statute says every pharmacist supervises pharmacy technicians. That makes you a leader, regardless of your role in the pharmacy practice field. And so I think that's very important, not necessarily looking at the extrovert, but looking at the fire in the gut, the passionate. It's a compliment. It's definitely not just looking for an extroverted individual.
Right.
Now,
Absolutely.
one thing, just like as a profession, just trying to push it forward, another thing that we have to keep asking ourselves, or of the profession, don't ask the question, where do I fit sometimes, and more, where could I fit? You know,
That's a good way to look at it.
So you have to, like, anytime, let's say a new service line is started, people are going to look at you like you're crazy.
Oh,
right?
yeah.
That's true.
You know, if I said,
I'm used to that.
eventually we're going to have every med rec in the hospital done before the patient hits the floor. Until it happens, they're going to look at you like they're crazy. Okay?
Music to their ears.
But so you have to keep asking yourself, where could this fit? Where could I fit?
Yeah.
So right now, at Memorial, one of like the bigger new projects that I've been having is thromboelastography TEG, which has now been a consistent conversation on a national scale, to the point where people are wondering, can I utilize this blood test to prevent DVTs? Can I use this to reduce the amount of blood products that a patient needs to get? There's a hospital in San Francisco where they were able to justify having a point of care machine because that hospital uses a very expensive reversal agent. And by being able to tell the patient is hypercoagulable at their state at that point, they know we don't have to use or have the patient spend all this money because this thing is point of care. It's a simple manipulation. So let's just say in an ambulatory care setting, a pharmacist can do an AccuCheck. Well, this one is also a simple manipulation. So why could a pharmacist not eventually use this machine?
Yeah, it's just medication management.
You know, it's just specific medication management tailored towards one thing. So you have to think, you know, where could this actually be applied? And then where does that expand to? ATLS, Advanced Trauma Life Support, does not have pharmacy mentioned anywhere in the book. You can't even get that certification. But I have trauma surgeons now calling, asking to interpret this test. If this is point of care, then that could be a potential role. Antibiotic stewardship, those kind of things that a lot of places. So you just think, you know, where could I actually fit? Where could this actually go to? And then those are positions that get created in the future.
And then taking it the next step and taking that pilot that might be successful within our healthcare system and bringing that to the masses by either publishing or talking about it, having a poster, and bringing it to where, again, it becomes something that's mainstream and that becomes the standard of care rather than the exception.
Yeah, it can change everything.
And looking at the profession from all aspects, right? From training, do we have the right training? Yeah. Do we have the right setting where to practice? I remember pharmacies being in basements, away from the patient care areas. I was working for a major retail drugstore as a district pharmacy manager when one day somebody woke up and said, let's take the walls down and let's not put the pharmacists behind walls with a little see-through window. Let's open up the dispensing areas and make the pharmacist available. So again, going back to that extroverted pharmacist, you may have an extroverted pharmacist, but if the vision was to lock them up behind a place where they're not accessible, that does not do us any favor. Yeah. So it's a whole list of things that you will have to say, what can we do as professionals, right, to drive our value? And that's making us accessible, not hiding us behind a little window. Opening up spaces. I mean, I know security is important, but opening up spaces, and that's why today you go to a CVS and you get an open floor plan where people have access. Why? Because CVS wants to provide that patient-pharmacist interaction that you cannot do behind a wall or a glass. Right. And so that's important. So from infrastructure facade of your floor plan, putting the pharmacist by the tower, if you're building a new hospital or if your hospital is going to be remodeled, where do you strategically position the department so that when they call a code blue, they can run to the ER. When there's something to the ICU, they can deliver to the ICU. And so I think there's a combination of things beyond the extroverted pharmacist that will give you a platform for developing advanced pharmacy practice.
And I think this really speaks to the evolution of our profession. I think that when Dorinda refers to that pharmacist behind, the walls, that's all pharmacist was. At one point, the family pharmacist was that person that they knew you, they knew your kids. You were the druggist. Yeah. And our role has changed, and we are not just the druggist. I remember in my pharmacy class, my professor stood there and he said, when I was in school, this old time, so my class was 80% female, 20% male.
That hasn't changed.
And right.
Still like that.
Same.
So, but when my professor was a student, it was reversed.
Oh, wow.
It was 80% male, 20% female.
Okay.
So the profession is changing. We are asking for it to change by placing ourselves in the ED, by placing ourselves in oncology and becoming part of that team. But really, the entire profession is changing. And I think the other thing too, healthcare is changing.
Yeah.
Our healthcare landscape is changing. And I say this all the time. We at Memorial, we traditionally have been a hospital system. And we are becoming a true healthcare system. And that means, to Sarah's point earlier, not just within the four walls of the hospital. Memorial,
Across the continuum of care.
Memorial is a community hospital. We're here to serve the South District. We are a community hospital. So it starts at the ED when the patient gets admitted, but then what happens when the patient goes home? And so our role, so for me, the time is ripe for pharmacy to become part of every one of those touch points. When they meet the patient in the ED with Brad and Sarah, when those patients are transitioning out of here, and then hopefully they never have to see you, but if they do have to see you, but if
We
they
can do donor drives. We can do
but
BMT
if they
donor
do need
drives.
to see, but really pharmacy is only aligning itself with where healthcare is going.
Yeah.
Healthcare is changing, so costs are changing. How many times have we heard drugs are expensive?
Yeah.
Every day.
What are we doing as pharmacists to change that conversation?
So knowing that, the landscape of pharmacy is changing, what is Memorial Healthcare doing to be in the forefront of these changes? What are you all working on, I guess individually, or what are you trying to do to advance your profession and your respective fields?
So I think one of the biggest things to come out right now, or one of our biggest focuses in general, is population health. And we kind of touched upon this earlier. But again, going from, we were at a talk about last year, Rita Shane, who's the ASHP's leadership program. She said something, and it's resonated with, I think, a lot of us since she said it. She said, when the patient's in the hospital, they're there for 5 days. What about the other 360 days? What happens then? There's pharmacists in ambulatory care setting, but it's still not as strong and not as robust as a hospital setting, right? So I think when she said that, I was like, that's true. We fix up this patient so well in the hospital. We do all these great services. We renally dose things. We fix their anti-coag. We do, and then we go, okay, bye. And then we send them out. And then what? And then so they have these touch points with the pharmacy, their retail pharmacy or community pharmacy here and there, but they're still not necessarily making those connections as well as they probably should. So from Memorial Healthcare standpoint, I think one of the things and one of our biggest focus and change is trying to look at our community as a community. Okay. We are trying to fix this patient, our community and keep them healthy versus waiting for them to be sick. And it was something else someone else said was, we used to report ED utilization and hospital utilization, and we looked at hospital utilization decreasing as a bad thing. But now we're trying to say, hey, that's actually a good thing.
Preventative healthcare,
Preventative healthcare. We're trying to be, proactive than reactive.
And shifting treatments in oncology, for example, from inpatient to outpatient, it makes a tremendous impact on people. So we can say, okay, well, there's less beds that are being filled with patients, and we have to reframe that and see that as a good thing.
Yeah.
And then also with and even with oncology, it's those checkups with physicians trying to catch things early
Right.
rather than waiting
Screening.
until the
Screenings
screenings
Yeah.
and everything like that,
Yeah.
preventative measures. And so I think that Memorial, as well as other healthcare systems, but Memorial has done a really good job of taking the lead and saying we are going to be more preventative than reactive.
And I think we also are becoming more and more mindful of the community that we serve.
Yes.
We have a very diverse community. We have patients who we serve who are part of ethnic and racial minorities, and we have to be mindful of that because there are major health disparities within our population if you compare them to the ethnic majorities. So in oncology, for example, if a patient has an acute leukemia and they need a bone marrow transplant, if they are Caucasian non-Hispanic, their chances of finding a match are around 80%. If they are of Latino background, if they are Black, Asian, or God forbid that they have a mixed ethnicity, those chances drop down to 20 to 30%. And so this is something that we need to fix within our community. We need to get our families, the people who are living in this community that we serve, we need to get them educated, get them enrolled on the bone marrow donor registry, and really help those that we're trying to serve. It is a really unique problem that we have. Same with informed consent for chemotherapy treatments. I have a lot of patients who are non-native English speakers. How do you deal with that? How do you overcome that? And so we've used technology. So what we have is we actually have a video translator service. We've had to have some quite obscure languages that sometimes you have to schedule it, but you want to be able to give everyone the same shot at a cure. And not just having them be disadvantaged just because their racial or ethnic background.
Yeah, in another patient population, the psychiatric population and addiction medicine, Memorial has done outstanding work as Memorial Pharmacist also. Just where you now have legislation where pharmacists with the right programs can administer long-acting injections and things like that. So as those programs, they get started, when they come into the ER and I see those notes, that following is just this nice, good touch point of revolving documentation. The less patients fall through the cracks. A heroin addict comes in and or an overdose patient comes in, they immediately get hooked into the MAT program or get offered the services. Just being able to offer those through a grant program, pharmacist-led, is just phenomenal.
I don't think any of the pharmacists who started these programs went in with the idea of, I want to be able to do blah, 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 blah. They always had the patient at the forefront. And I think Memorial as a healthcare system really makes a point of having that patient and family-centered care. So all of these programs came from with the vision of how can we help these patients to the best of our ability. And so that's how we were able to expand. And then the nice thing that flows with it is that we were able to advance our profession at the same time.
You mentioned technology and how you're utilizing it. Obviously, we're in a technology world right now, as you guys can see right now. How is Memorial, I guess this is for everyone, how's Memorial utilizing technology and how's it helping? Is it benefits, not good, and both aspects of it?
So depends on what kind of technology, but I think that we are known as one of the most technologically wired healthcare systems in the United States. And in pharmacy, we use technology to leverage what we do every day. Again, if you utilize technology, we're going to become more effective. We're going to free up some high talented individuals to do very high level cognitive services. So for example, in the IV rooms, we use IV room workflow technology to improve the safe preparation of compounded sterile medications. In the pharmacy, in the main pharmacy, we use automation to get the drugs to the patients at the right time. So we rely on our inventory systems and our Pyxis platform to deliver medications to the patients at the bedside. I recall when we used to have to deliver every medication to patients, right, from the pharmacy. We're able to put the medications by the nurse when they need it to do real-time medication distribution. And I think that sets us apart from everybody else. For example, here at the home infusion pharmacy, we want to carry, talking about that integration, what are we doing to make patient care and pharmacy better? In Memorial, here at the specialty pharmacy, we're deploying technology in our infusion facility to be able to utilize technology to take away some of the high-level compounding that's done in the hospitals, as well as our TPNs, again, relying on technology to decrease the likelihood or minimize the likelihood of errors associated with compounding. Those are some of the things that I know that we're doing as a healthcare system, utilizing iPads at the bedside to do counseling when we do meds to beds, so that the patient that's going home has the ability to talk to a pharmacist before they leave if they have questions about their medications, to be able to charge them at the bedside. I mean, it's
telemedicine
is
patients.
Actually, one of our, I know at one of our hospitals, they have implemented a telemedicine format where they do MedRec and education with patients pre-bariatric surgeries. So for our bariatric population, they will actually set up an appointment, and a pharmacist will meet the patient and or caregiver to go over the medications, do their medication reconciliation via that method, and go over the educational points, such as, there are certain meds you can't crush or certain meds you can't take at that point. And then it's all documented using MyChart, which is our patient-friendly portal for Epic. So I think that's one of for me, when you guys asked that question, that was actually the first thing that came to mind. And I think that technology we're potentially going to leverage throughout other areas. And I think they started it, which is great. Obviously it comes with its disadvantage, because if you have a patient who's in their 80s and I mean,
not super tech savvy.
So one of our things, it's not necessarily pharmacy related, but it's still a really cool thing that I know for transitions of care we use a lot, is home health care actually has these telemedicine portals where the patient will step on a scale, put their arm in a blood pressure cuff, and everything is translated into Epic.
That's good.
Just from their home. So there's no need for them to come to the house. But I've talked to patients who are like, get this thing out of my house. I think it's listening to me and talking to me.
Yeah, so it's not for everyone.
So they're like, it keeps beeping. Take it out. I think it's listening. So I'm like, okay, we'll work with that. But it's fun. I mean, we have a lot.
And we have, the doc in a box.
Yes.
And we have a doc in a box program where we actually.
Is it literally a doc in a box?
Yeah.
Because I would love that.
Okay, not literally.
So doc in a box makes access to the patients that can't get out of their house.
Okay.
And we go see the patients. We also have a community van, extremely well equipped. It's stocked by our pharmacist in one of our hospitals. The van goes out there, provides, monitoring, and remotely, and is out in the community taking care of patients that cannot make it out of their home to seek patient care. And guess who's attached to that mobile van? A pharmacist doing medication reconciliation, helping the physicians figure out what is this patient on.
Because they're all taking little white pills.
So
I don't know the name. It's the little
getting out
white
in
one.
the community, mobile, on wheels,
That's awesome.
giving access to patients, I think is another thing that Memorial does very well. Not waiting for the patients just to get to us, but us going to the patient and
But one
delivering
thing that I have seen, and not to sort of be the negative Nelly in the group,
There's always one.
Wait, okay, go.
Okay.
so I agree, technology is fantastic, but unfortunately the downside is you lose critical thinking.
Yeah.
True.
And you truly lose skills because of the over-reliance of our technology. I think, I mean, one of the things that I do in my role as med safety is I work very closely on order sets and order set development. And the physicians, if it's in the order set, they assume it's correct. They assume it's okay. and you lose some critical thinking there. Or we over-rely on the technology to double-check us.
Yeah.
That's true.
And as pharmacist, I can tell you when I sit in an RCA and
What
they
is an
ask,
RCA?
an RCA is a root cause analysis where an error occurred, and you try to get to the bottom of what happened to mitigate the risk.
And there's a lot of alert fatigue.
You know,
things like
there.
that.
Yes,
Yeah.
it's because we are waiting for someone to tell us when we're not doing something right and we're not thinking critically. So I challenge you guys as sort of the next generation, because you guys grew up with technology. It's part of what you do. It's we're here on a podcast. I challenge you guys to utilize technology, but to ensure we still have safety. Because I am very concerned with that loss of critical thinking, whether it's nursing critical thinking, it's pharmacist critical thinking, and even our physicians. You know, they're relying heavily on the computer telling them what to do.
Well, how do you think you get that balance?
That's why I'm telling you.
That's where we come in. That's where we come in.
Okay.
It takes two to solve it.
Keep this going and don't heavily rely on that.
Just don't do
You
your
have
own
to
test.
use both,
But sometimes there is so much information out there that you can use automation to your advantage. We're looking actually to implement an artificial intelligence software for our oncology patients because historically our enrollment in clinical trials, so clinical trial really is the best option for any patient who gets diagnosed with any type of cancer, really. But you can have opened a clinical trial 7 months ago and now you see Mrs. X and you don't exactly remember that she might be a candidate for this trial. So we're looking to have an artificial intelligence software help us and help flag those patients. And yes, having that little prompt will then help the pharmacist and the physician come together and say, okay, this was tagged. How do we go from here? And so I think there are
there's
really good
definitely
situations
there's pluses and minuses. I
Yeah.
mean, I definitely remember in pharmacy school, you know, the first thing they teach you is if somebody asks you something and you don't know it, it's okay to say I don't know.
Yeah.
It's okay to say let me look it up. You don't want to provide misinformation.
Right.
Absolutely. And I agree there's so much information, but I have seen heavy reliance on the technology.
Yeah, I understand.
Where we are not, you know, we're not thinking critically and we're not doing what we should do, which is some basic pharmacy stuff.
I understand.
Because, you know what? Epic didn't flag me that this dose was wrong.
Fair enough.
So it's finding that sweet spot. I think it's really about finding that sweet spot of utilizing technology and leveraging it. I'm all about leveraging
Yeah.
it. It's leveraging it, but at the same time,
Just don't rely on it.
exactly. It's that over-reliance.
Yeah.
And
Because then
finding.
why not replace us with robots?
Exactly.
Yeah.
And then
So
that's
you
not showing
still
our
need
value.
exactly.
Things
So
like
you
that.
still need
Right.
to use your brain because it's you have to. You have to have some sort of human.
Would hope so.
Humanistic approach to this,
Yeah.
or else
Right,
you
but now
guys
they're going to
are-
have computers and robots that feel, and they can essentially replace us.
Sometimes it's something so simple like one of the big things that leads to errors is an abundance of phone calls to the pharmacist while you're trying to verify something.
Interruptions.
Just interruptions in general.
Yeah.
So one thing that at Memorial, one of the number one phone calls I got is, hey, where's my med at?
Oh yeah.
So somebody reprogrammed an iPhone, put some cases on it, and then you can scan it in real time. This medication is being delivered. This is in the Pyxis. This is in the refrigerator. And that dropped our phone calls by about 50% in the ED alone. Just by that, because the nurses can see every step of the way what's happening.
like when you track your package in
Yeah.
the mail.
Yeah, we're just about to
It's
say.
just
We're in your house right now.
It's just like
Absolutely.
that. Or then if you forgot to print it, I know, I forgot to print it. Let me go get that right now.
Yeah.
You know.
I mean, let's be honest, there's so many mundane tasks
Yeah.
that everybody does. And if you can leverage technology to help with some of the mundane tasks so that we can then focus on the clinical tasks, at
Exactly.
least, you know, I think oncology is very different. It's a whole other sphere with AI. I'm just talking about basic
understand.
clinical operations. If you can have meds readily available and you don't have to be that person delivering it, then that pharmacist, they can then be, you know, really operating at the top of their licensure, which is what we're here to do.
Yeah. Or also creating an avenue to get the information that needs to be made in order to initiate that medication intervention.
Yeah.
So one of the things, and this is really big with the stroke program, was getting a single sign-on onto a program where you can search a patient's home medications without talking to them. So you can identify an anticoagulant or something that would contraindicate them from TPA. You know, something that small will be huge, and there could be thousands of patients nationwide that get that get TPA while on a blood thinner and then have a poor outcome because that was never made available or set up.
So I want to end on a fun question. This has been a popular question. We've asked it before, so I want to go around. I want to get an answer. I want to get an answer from everyone.
Okay.
It's not the interview question where it's like, what drug would you be?
It is not that.
It is not
Okay.
that.
It is not
I
that.
don't know if that one will be the popular one.
That boo.
So, if we
And
were
even
to,
if it were, it's not going to be it now.
that's where the editing comes in, right? If we were to go back to undergrad or pharmacy school,
Or
would
high
ask
school.
your friends
Or
and
high school.
classmates or high school who you were, who was Dr. Segovia, who were you? What would they
Start
say?
over there.
We'll start.
They probably
Don't
remember
lie.
high school more.
Don't lie.
Just start over
Okay.
there.
Because we will go ask.
Let's see, introvert and sits with the same 3 people every day for 4 years.
Really?
Okay.
You sat with the same?
Same, yeah, I had my row, and then as the classroom was changed, I sat in like the same row. It was like third from the top to the left on the inside.
Do you have
yeah.
the same breakfast every morning?
Yes.
Do you
Yes.
really? You're just a creature of habit. And
Park in
that
the
just
same
makes
parking
you-
spot every day.
Oh, that's me.
But then,
Yeah?
One of those.
but then every once in a while, I would pop up and do something that was like not an introvert thing to do. So
And they're gonna be like, "Are you okay today?"
yeah, they're like, what?
Riley,
Like,
you dance.
like I
How
would.
can you be a dancer and
Well,
be an
that's the thing.
introvert?
That's new. So when I was in pharmacy school, I actually started a step team, and
Wow. Yeah.
but I was so quiet, nobody realized that I was one of the founders for like every year. So they'd be like,
I can see that.
they're like, "Yo, you should go to the
Dance
Rampage
balls.
show," and I'm like, "Okay."
That was,
And then so then they show up and they're like, "Why is he on stage?"
It's because of me that this is.
That's awesome.
That's awesome.
So people would tell you to go to your own.
Yeah, they had no idea.
That's hilarious.
They had no idea.
That
Are you
is
going to the
amazing.
step thing? Yeah, I'll be there.
Yeah,
I'll be there.
Yeah, maybe. I'll see if I can make it.
Yeah.
That is amazing. In pharmacy school,
High school.
High school.
High
It
school.
can be either,
Yeah, let's
whichever
not do
you
pharmacy.
want, whatever.
The one that's more interesting.
Oh,
I'm
man.
kind of bored. I mean, I
mentioned
followed the rules. I said yes to everything, and I played a lot of sports. I don't know. That's.
What sports?
Boring.
So I came to the U.S. actually on a tennis scholarship
Oh, wow.
because I didn't want to stop playing tennis and I wasn't good enough to go pro. So I came from the Netherlands to Texas, where everything that we have as a preconceived notion of what an American is actually true. So I stepped out and I was like, wow, it is just like the movie.
They're all cowboys.
So yeah, there's a lot of trucks and
Everything's big.
food. Yes.
bellies.
I didn't realize that that's just
Texas.
Texas. So that took me a little bit
But
to
Texas
catch
is
on.
the United States.
Yes, it is.
Well, they like to really make a big point that they are the U.S., but they're also Texas, and the Texas flag is the only state flag that can be hung at the same height as the U.S. flag. The other ones have to hang lower, but
Oh, wow.
Texas
Really?
Texas is its own thing.
You learn something.
Yeah,
Yeah, I didn't know that
Texas. So, so played a lot of tennis, liked chemistry, philosophy. So, naturally from there flows pharmacy.
Yeah.
Totally.
Makes sense.
And in
Beautiful.
pharmacy, my pharmacy school was right across the beach, so I would skip ID and go to the beach instead.
You skipped
Sorry,
school. You said that you
doctor.
followed the rules.
We're gonna cut that part out. We're gonna cut that part out.
Sorry, Dr. Shaheen, love you. I just never liked ID or oncology.
Whoa.
Those were the two that I skipped.
We're going to cut that out of the end.
Don't
So
skip
if you were
class,
not gonna be a
everybody.
pharmacist, what were you gonna be?
Oh no, we're not.
If I wasn't going to be a I would probably love to have either a travel show like Anthony Bourdain, or maybe be a private chef for like a super wealthy family, so I could just have fresh truffles
Are you
and
a
You
good
can
cook
cook
for
well?
them.
This is
Yeah,
important.
this is
I
important
enjoy
question.
it. I
No,
enjoy
that
it.
answer
no,
my
that
question.
wasn't-
Are you a good cook?
Yes.
So are you gonna bring us
Confidently.
something to
I'm not a
confirm this?
caterer.
Okay. Well, I mean, you can still. I want to confirm this.
Start small.
Okay.
And then you can
Amanda, we
expand
have
into
to
your
talk.
rich family.
So, did you have a Friendsgiving for everyone?
No.
Again,
Wow.
I'm not a
No.
caterer.
Really?
She did
She doesn't
not cook
cater.
for us.
She's
Like
not.
if you know of extremely wealthy family who needs a
You'll
private
cater for
chef,
them.
Okay.
let me know.
But start here.
Yeah.
Charity starts at
We'll let you know how good you are.
Thanks.
All right. So if you were to ask my friends from high school what I was like, so everybody knows high school has the cool kids,
Yeah.
and then there's those not
were
so
a
cool
cool
kids.
Yes.
I was not.
You were not.
We didn't go along with everyone else. So I definitely was. So interestingly, I went to a Jewish school, which is parochial school. So like you, I had to follow rules, and I'll never forget. I was in like the regular class, and my freshman year, I get a letter from the principal that says, "Meet me at the beginning of sophomore year."
Uh-oh.
Never a good thing. But I actually was asked to be placed into the honors class.
Oh.
And I'm going to tell you that changed my life because somebody saw something in me and I proved it to everyone because I was the newcomer in the in the honors class. And so there's no way in hell I was going to be at the bottom of that class. So it made me work harder than anyone else and really challenge the status quo. I have always been trouble. And I've always.
You can't tell, right?
Not anymore. Not anymore.
No, I am. No, but I challenged status quo, and I've challenged it from the beginning. And I didn't have to be part of the cool kids. I was just always the nice kid.
Okay.
So I think if you were to ask them, I was nice, I was smart, an extrovert. But when I needed me time, I needed me
I
time.
understand.
And so here I am today.
And what would you do if you weren't going to be a pharmacist?
If I wasn't going to be a pharmacist, so I've always wanted to be a doctor, but truth be told, something in fashion.
Okay.
I love clothing. I love shopping. I just don't have enough money to do it.
I hear you.
But I love so you cook for the rich,
I will
and I'm going to
give
shop for the rich.
Right. Would you actually enjoy it even if it's not for you?
Yes,
Yeah.
I enjoy. So actually, one thing that I'd love to do is I think there is a huge need for executive women to have the appropriate clothing. I think as women, especially in executive positions, there's the two sort of camps. There's the one that needs to dress like a man, and I'm in the man's world, and then there's those women who are out here, and I think that there is really not you. No, but just
lipstick and a scarf.
so I think that a strong woman needs to dress her part. I think you can be feminine, you can be strong, and I don't think you need to compromise that. So if I could do anything different, I would bring fashion into
That's
sort of
where
the executive world.
We're gonna go
Rita
shopping.
Shane
It's never
also
too late.
inspired me for that because she just dresses how she likes to dress
Yeah.
and doesn't go
And
along
other than
with
there don't need to be rules.
Yeah, there doesn't.
I think that, and I've spoken to a lot of women in executive positions, and well, I'm in the boardroom now. Well, that doesn't mean you need to lose who you are. And so that's what I would do if I wasn't in pharmacy.
Oh, did I forget to answer the second question?
Oh yeah, you never answered yet.
Oh, snap. Okay. So, I had always wanted to do music and production for Cirque du Soleil.
That's very specific.
Yeah, I was gonna say, that's extremely specific.
I thought you were
I was
just
just
stop
saying
at
music.
making
Okay.
That is what I had.
Was
That's
that
what I had wanted to do.
like how old were you when you
Oh man, this
was that
was
like teen or
this
later?
was from 14 to like 20.
Wow.
That's what I wanted
Why
to do.
Cirque du Soleil?
because it's
It
so
was-
artsy.
it's so
It's
cool.
so cool.
It
Oh, I
was
know, I love it, but
like especially the music and then the light shows and stuff because I always liked production and
Man, it was so
band and
boring.
like operas and Broadway and stuff like that. So I always wanted to like produce a show or like
Yeah.
know
I
how
wanted
do
to
that.
win a Nobel Prize when I was little.
Did you?
I do.
You didn't win? I thought I saw.
No, I feel like at this point I would only be able to win a peace prize and I would have to do a lot more because the rest is all bench work. Although
Yeah.
the physicians that won for personalized, like for immunotherapy, but
Right. You never
it's
know.
tough for a pharmacist. So now I think I'm shifting my goal to maybe one of my students or someone that at some point I inspired will win a Nobel Prize.
Maybe your kid.
And then
Oh yeah.
The one, maybe. I have a good twin and an evil twin. The
evil's gonna win.
Gotta know your personality.
Yes.
Gonna win.
Yeah,
Always.
gotta know my
Evil always
people.
wins.
She's like, you know who I'm talking about.
You know, Alexia.
All right. So me in high school versus me in pharmacy school are like polar opposites.
Really?
Polar opposites. I don't know what happened. It's like the second I stepped onto the college campus, I went, wow!
I can see that.
Yeah, so in high school, I was completely introverted. I would say sorry for everything I did. I was like, oh my God, I'm so sorry. You know, kind of like that
Good
middle
girl.
ground. Yeah, I was very good girl, didn't do anything wrong.
Until it came from school.
And then all of a sudden, literally, I went to Rutgers, and like the second day, I was like, oh my God, this is what freedom feels like. And then I became that very extroverted, outspoken, definitely that person in the class who like raised their hand and challenged what
You were that student.
No, but I wasn't the front sitter student who raised. I was the back seat, or I would be the one like playing
Rolling
Sudoku.
her eyes.
Yeah, 100%.
Are we ever gonna need to know this?
Yeah. But I was definitely like the playing Sudoku. But I always thought sitting in class, like I was like, oh my God, I'm totally the dumb one. Like I don't know what I'm doing, but I did well in school.
I think that's
I
a
feel
lot
like
of
I know.
imposter syndrome that
Yes.
pharmacists tend to have.
Yeah.
So I think that's just kind of prevalent in our profession. Like we always kind of feel like we don't belong.
Yeah.
And
And
I
I
still
don't-
have it. And the more that I learn, the more that I feel like that.
Yeah, and
So-
I definitely felt like that. So that was me in pharmacy school. So I don't know what happened, but like I just changed, like literally like smelled freedom and became different. And it definitely changed the way even me as a practitioner.
Okay.
What would I actually know the answer to? Though what would I have been? I actually really, really, really wanted to be an engineer.
Really?
Really wanted. I loved anything with engineering and kind of like fixing things and.
Okay.
There's your
Just-
IT person.
There we
Yeah.
go.
Well, actually,
And she has a background in informatics.
It is.
no, not informatics.
Drug information.
not
We
informatics,
can
but.
put a hand in
And
hand.
this is the
Sure.
reason why
Close
she's
enough.
re-engineering continuity of care.
Yeah, there you go. I like so but my
marketer.
dad, marketer. My dad was like, "You're not going to be an engineer. You're gonna do something else," because he was an engineer. But I actually come from an entire family of
My
physicians.
dad did that too.
Oh, okay.
So
My dad did that
I
too.
call myself the black sheep of my family because I didn't go into the traditional
Yeah.
medical role, but everyone in my family is like, you're the smart one. You did it the right way. So that's kind of my answer.
Awesome.
That's good.
Last but not least.
And I must go back to high school, right?
Yeah.
You don't know how
Middle school, elementary, wherever you want to start.
Just kidding. Actually, I prefer to go back to high school. Just looking back, I was lost in high school. I arrived to the United States when I was 16 years old in 11th grade, did not speak the language.
That's a
Remember
tough
walking
age.
into the
Yeah.
boys' bathroom. Remember raising my hand my first time in my chemistry class because I did take chemistry as an elective instead of taking keyboarding like everybody else.
Rookie.
And so I remember my first chemistry class with my broken English. ESOL classes did not exist back then. And I raised my hand and I said, teacher, and the entire classroom just laughed. And I said, what did I do wrong? Aren't they called teachers? They're like, no, here they're Mr. and Mrs. So that was quite an experience. I was pretty lost. Didn't know you had choices to take electives because that's not something I grew up with. I did not know how to but how to multiply and divide the American way. So I struggled myself through my 11th grade just because I didn't know what some of those symbols were. And so I was pretty
Or what a
lost in high school.
numerator or denominator.
And then I
was 20 when I
some of
learned
my
that.
professors, my English professor, interestingly, and my math professor said, you don't belong in this class. We're going to advance you. By the time I finished high school, I was reading Macbeth, and which is what the normal kids in, honors English classes do. So I managed to get out of high school. And I remember taking this test in the cafeteria that I didn't understand what it was for. It was the SAT. And little do you know, then you go to college. But that goes to tell you I am a first generation immigrant.
Yeah.
My parents did not know how to help me. My friends were all recent immigrants too. And so figuring out high school was tough.
Okay.
I had fun. I would say I was the SGA president nobody knew about. Does that make any sense? So I was doing things in school, but not really having any leadership roles. And we were just, my high school had the Americans and the immigrants.
Okay.
And they had 2 parking lots, and it was the immigrant parking lot and the American parking lot. And it was very interesting how it was segregated, even though it was the mid-'80s. So, but I survived high school, went into college, and I went from being lost to being confused, if that helps any better. In the 80s, if you were going to college, you must study computers. So Dorinda registered to study computer science. And I am a extroverted, hyper, and I like change all the time. And my first computer class, I missed a semicolon in the lab, couldn't figure out why the program wasn't working, and I said, that's it. I forgot my book in an open book test, and I said, this isn't for me. I transitioned into medical technology, trying to get myself into the healthcare field, because there's one thing I always knew is that I like healthcare.
Okay.
How did I even try computer science? Again, confusion was my undergrad in junior college. And so then one day somebody said to me, how about pharmacy? They were opening a college of pharmacy in Miami Beach. I said, well, that's close enough to being in the healthcare field, but do pharmacists sell fishing canes? They did, and hair coloring. And when I went to the pharmacy, I saw the pharmacist advising customers of a drugstore, oh, yeah, the clay roll is on aisle 5. And I didn't connect to pharmacy, and it was until someone said, why don't you get a job as a clerk in a pharmacy? Maybe you change your mind. And so I went ahead and said, okay, I'll try it. And it was within, I would say, 48 hours. I said, this is for me. This is really for me. If I wouldn't do pharmacy, I would do pharmacy all over again.
Oh,
That's
a
a
great
great
She got you guys. She got you guys.
However, well,
You
because
guys can't change your answers now.
Yeah.
I want to be pharmacist too.
No, I don't change my answer.
I will like as a hobby, and now I'm closer to retirement than when I started my career. And so I really like to go to chef school, and I really like to play the piano, but in terms of profession, I would do it all over again.
So can I tell you how nervous I was in the beginning?
Really? You couldn't tell?
You'll do it again now.
Oh my God, I want to just keep talking. I don't want to go.
Exactly.
This is a lot of fun.
They made it very casual.
Yeah.
We appreciate you guys
Thank
joining
you,
us.
guys.
And we appreciate everyone tuning in wherever they are in the world.
Bye.
Say hi.
Hello.
So we appreciate you guys, and thank you guys for accepting our invite. My name is Nima.
Oh, man.